Okay, so we today we have another interesting presentation. Welcome to Psyche, a collaborative initiative between KNUST Wellness Center, Department of Behavioral Sciences, KNUST, then KNUST Counseling Center, as well as St. Patrick's Hospital of Finso, the Wellness Clinic at St. Patrick's Hospital. So today too, we have another interesting presentation. Just like always, we have a colleague of mine by name Dr. Pearl ADU-NYARKO, a specialist psychiatrist at Komfanache and also a lecturer at the Behavioral Sciences Department, KNUST. Doc, please, can you hear me?
Yes, I can. Can you
Great.
hear me?
Yes, I can. Thank you for coming around. Thank you for honoring this invitation. I don't know if you can put your video on so we can see you.
Okay. Great.
Oh yes, and that is Dr. Pearl. I mean my favorite pet name for her is 16 years. Forever young. Yes. So Doc, if you are ready, please be here as well.
Okay, great. Thank you for having me. And I hope we have a wonderful time this evening. I was going through the slides myself. So let's go to the beginning. And for this evening, our topic is on mood disorders. And I told myself, we always say mood disorders. And so how do I make it exciting, even as we are looking at the topic of mood disorders? And because there are so many variations of disorders that have to do with our emotional well-being, I decided because we have just 1 hour and we need to have time to interact in order to exhaust the topic, I'll focus on depression. And even though we are looking at depression, my key objective is to let us be able to recognize what depression looks like, demystify our perceptions or our understandings about it, and pick some tips that can help us prevent or offset the onset of depression. So you see that for my title, I said depression prevention. And that's because I'm hoping that if you don't take anything home at all, you would pick pointers that will help you prevent depression in yourself or prevent people you know who have depression from having relapses, or even prevent worsening of their symptoms or prevent future occurrences. So we'll be looking at introduction, a few definitions, try to make a case for depression, looking at the data, and look at the causes as we understand it now, risk factors, and increasing risk factors that increase the likelihood of us developing it or our loved ones developing it, protective factors. So there are things that if they are present in your life, they actually protect you against developing depression. And then when we've made that case, now we need to be able to recognize it. So we'll be looking at what does it look like, so that the mental pictures we have can be aligned with what depression actually looks like. What the clinicians see is what we call the signs, and what you and I see with our lay eyes is what comes to us as the symptoms. Then we'll now look at the prevention, and at the prevention, I'll bring in a little juice, which is in the form of recent guidelines and updates that we have published in February 2024 as very effective ways of dealing with depression. That will serve as a way of looking at treatment methods. And then as our conclusion, we'll have some discussions and additions to the topic. Then I hope that we can be out of here. So first and foremost, depression has so many names depending on the culture you come from, the language or your ethnicity. It's been given so many names. And if roughly I was to ask you to pick one word that you could use to represent depression, I have a picture here. This some selection of some of the words, but I'm sure that we could add on to it. Sometimes depression spells irritability. Sometimes depression spells helplessness, worthlessness. Sometimes it spells restlessness. Sometimes it spells fatigue. Sometimes it's associated with grief. And there are so many different words that we can use to describe it. Maybe at the end, I'll let us add on to that list by each one of us putting into the chat box. So even as I go on, if you could briefly just put one word into the chat box about how you, the local people close to where you are, describe depression or call depression on a day-to-day basis. Just briefly slip in a word into the chat box about it. So we'll be looking at the definitions, and under the definitions, we'll be talking more about the signs and symptoms. And then we'll also be looking at what causes it. And under the causes of depression, we will also identify the risk factors. What does depression do to our body in general, as way of making the case for depression as part of my introduction? On the brain, there are some particular symptoms that we might notice. Disturbance in sleep, which can present as a complete loss of sleep. Sometimes headaches, fatigue. For the general body, it can result in symptoms like chronic pain that all investigations might not localize or be able to tell us exactly what the cause of the pain is. Then on our blood vessels, it's been found to increase the risk of developing heart diseases. Yes, depression can do that. And then again, on our digestive system, it has been found to affect our weight, our total weight. So we have noticed a loss of weight in some people with depression. And here I must say that in another age group or set of people who experience depression, instead of weight loss, there is weight gain. And these are the ones that are in the atypical group. And then also nausea has been recognized as one of the effects that has been identified in people with depression. Diarrhea and constipation has also been identified in people with depression. On our reproductive health, symptoms like loss of libido or a decrease in sex drive or desire for sex, or even a reduction in the pleasure experienced during sex, dyspareunia, has been recognized in people with depression. Then inflammation has also been recognized. In fact, the most recent findings of a work that was done by the European Community for Psychopharmacology, a study that was presented in our recent summit, showed that there is significant increase in the amount of C-reactive proteins. C-reactive proteins are the proteins that we produce when we have an infection that requires our body to produce inflammatory markers or produce molecules that deal with any situation that the body needs to contain. Your immune system sends a lot of messengers to help clear that problem out. And the study was showing that there's a significant increase in these markers in people with depression. In fact, that study was seeking to even suggest that it is possible that we should be in future considering giving anti-inflammatory medications to people with depression. But the problem there is being able to identify which group of people presenting with depression have an increase in these markers, and therefore which group will benefit from anti-inflammatory agents. Again, it is very important to note that this figure I'm showing here has increased since COVID. It has moved from 1 in 8 women experiencing depression in their lifetime to 1 in 6 women. And it has also moved to 1 in 4 men. That's about 2 in 10 men, roughly, experiencing depression. And the risk of depression in women has been found to be twice the incidence that we notice in men. Why do we need to actually scale up care for depression? Still making the case for why we should be talking about depression. Of all the conditions that afflict human beings in our life, and of all the conditions that contribute to disability life years, that is the amount of your life that is spent unproductive because of ill health, it was found that 12% was the contribution of depression to any individual. And that was quite significant because this was higher than the disability life years associated with cardiovascular diseases, which is our most feared health challenge. And so it means that we need to really take depression seriously. And annually, on average, about 5% of people living in communities experience depression. And the amazing fact about this is that even the literature is showing us that about 60% of the people who attempt suicide as a result of depression actually do come into contact with primary healthcare physicians in up to about 6 months prior to when they did attempt or complete suicide attempts. And just as I showed in the diagram earlier, the impact of depression on your physical health is so immense that we need to really pay attention to it. Again, depression has been found to contribute significantly to problems of treatment in people going through chronic health conditions. And in Ghana, this data has changed since COVID, but in 2002, the survey reported about 11.9% as the incidence for self-reported depression. And this figure has increased, but it still does not make up for the gap in treatment we have when it comes to reporting for treatments. Again, 12%, 2 to 5% prevalence is what we are seeing annually or in every year. And of the mood disorders, we also have a very common presentation called dysthymia, which has features similar to depression. We'll be looking at the symptoms of depression very soon. It typically presents like depression, but it's of a more debilitating or a more severe presentation than our usual depression. And the lifetime rates, as at this time, the time of this study was between 10 to 20%. And this has also gone up. The mean age is between 18 to 44. And on average, people around 27 are experiencing quite a significant presentation of depression. And as I mentioned, the incidence in females has been found to be higher. And yes, depression can occur with other mental health conditions. Looking at the prevalence of depression in people with physical diseases, this study looked at 70 countries, and these are the top 6 conditions that were picked up, that the prevalence was highest in people experiencing conditions like tuberculosis, HIV was second, cancer, hypertension, diabetes, and acute cardiovascular conditions like myocardial infarction. And these prevalences does have an effect on the outcomes of people suffering these conditions. What are the causes? What are the risk factors that we have identified when it comes to depression? Yes, we know from studies from twins and from genetic studies that our genes do present us with some predispositions. And typically, we observe that if you have a first-degree relative, your mother or your mom's sister or your sibling or your twin presents or experiences depression, then the likelihood that you have a genetic predisposition is high. Not to look down or disregard the contribution of environmental factors, because we know that we're a combination of genetics and our environment. And yes, environmental factors, type of parenting, sociocultural context, and other socioeconomic factors do contribute. But at this point, we've recognized that all those factors aside, there are genetic markers that also exist to predispose to developing depression. Then experiencing trauma like psychological abuse, physical abuse, neglect, violence, even trauma, physical trauma, injury from accidents has also been found to predispose to developing depression. Then biochemical imbalances, and these are often seen when we are looking at endocrine conditions or even acute illnesses that result in chemical imbalances or electrolyte imbalances have been found to also come with an increased risk of developing depression. Then encountering debilitating medical conditions, as we saw earlier, conditions like diabetes, cancer were lower. Conditions like retroviral infection, tuberculosis, chronic health conditions have also been found to come with an increased risk of depression. Then severe neurological conditions, cardiovascular problems, heart failure, developing CVA or stroke, and stroke that's significant enough to result in individuals losing their capacity to perform activities of daily living have been found to come with a higher risk than more milder neurological conditions. Then endocrine conditions like thyroid toxicosis, hypothyroidism, immune disorders like systemic lupus or multiple sclerosis, and there are several other endocrine conditions have also been recognized to contribute to depression. Again, looking at areas of nutrition, some nutritional deficiencies, especially in the B category, have been found to increase our risk to developing depression. And then also use of medications, unprescribed medications, and some illicit drugs also come with an increased risk of developing depression. Then our very good friend of life, stress. Stress is also one of the identified risks or causes of depression. Let's go further to say chronic stress. So acute stress does not typically result in you developing depression unless you have significant underlying predisposing or perpetuating risk factors. Then an acute stressful situation can increase your risk and lead to you presenting with depression. Again, personality traits and personality disorders, some have been associated with an increased risk and being causal in developing depression. Poor social support systems. Individuals who, for one reason or the other, find themselves with very little social support have been found to have an increased risk. And then I talked about chronic inflammation being recognized in people with depression, and then also health or medical conditions that are associated with chronic inflammatory processes like systemic lupus or multiple sclerosis, and also other brain disorders. An increased risk, however, is recognized if one has a past history of depression, if one has a current mental health disorder, and we know the dynamics that come into play, especially in our cultural settings when it comes to experiencing mental health disorders because of stigma, ignorance, social isolation. Developing a mental health disorder can actually increase your risk of depression because of other factors and not only just because of the mental health problem you have. Again, someone who's had a past attempt of suicide also has a significantly increased risk of depression. Individuals with personalities that are associated with internalization of behavioral problems. So you have people who are introverted or people who have adapted behaviors of keeping situations of distress to themselves and not reaching out for help, have also been found to present with an increased risk. Then individuals with physical symptoms of depression are at risk of very likely having depression. And young women are also more likely to experience depression. And this one comes from the hormonal theory, where it's been found that the estrogen hormone increases the risks in women developing depression. And therefore, in our reproductive age phases of our lives, postpartum, peri and postmenopausal, adolescent age stages, women are at a higher risk because of the hormonal levels to developing depression. Social factors like unemployment have been found to increase one's risk. Kindly mute yourself, please. Yeah. And so I mentioned poor social support. So the risk is increase in people who have few family members, people without any family support. And so comparing single status to marital status, people who are married tend to have a better risk profile. Please, can you kindly mute yourself when you join us?
Exactly. So, please, the IT technicians, can you please mute everyone when it's time for discussion? Then you unmute. Respectfully, the IT person. Can you please mute everyone?
Wait, thank you.
Matilda, please mute yourself.
I think Matilda is muted. Okay, thank you. So risk factors like loss, and it could be loss by way of death of a spouse, has been found to be the highest on the home scale of risk, stresses, life stresses. Losing a life partner, a spouse, is the #1 risk for the impact of stress. So loss of a spouse followed by loss of a loved one, investment, an expectation, loss of financial loss, loss of safety, loss of security. The other forms of loss also come with an increased risk of developing depression. Then problems with interpersonal relationships. So personal turmoil, family disputes, disputes between friends, siblings, parents, and children, worker, employee, amongst employees. Interpersonal conflicts also increase our risk of developing depression. Then abuse. Abuse of all forms are linked with emotional distress, and therefore all forms of abuse come with a potentially increased risk of developing mood disorders and, for that matter, depression. Let's look a little more into the life events that come with our increased risk. Some life events come with a lot of pleasure, like getting married, having children, getting a new job, moving to a new environment can be exciting. But when you encounter challenges or types of stresses by way of performance, expectations, the need to conform, the need to adjust to these new things that you may even have been longing for, the demand these new experiences draw on you can actually increase your risk of developing depression. And here I mentioned change. Change is one of the good things that can come your way: a new job, or you lose unemployment and you get a new job. You lose an income and you gain a new one. And all these come with an increased risk. So you're excited about getting married, and you get married, and you have expectations, and you discover they are not exactly as you imagined it to be, or the marriage comes with demands. You lose your income right after marrying, or you are now struggling with fertility, or even the marriage fails and you're in a state of divorce, or you've been working your whole life, a very successful career, and you've planned your retirement, and retirement comes. It can come with a whole lot of change that can increase your risk of developing depression. Not to talk about the scenario where you go on retirement unprepared, then you have twice as high an increased risk as the one who has gone on retirement prepared. And again, I put here, having a baby. It's exciting to have a baby, preparing the place for the baby, your expectations for the baby, going through the pregnancy period and all its physiological changes. The baby arrives healthy, and then the demand to care for the newborn can come with the risk, or the physiological demand for taking care of a new baby can increase the risk. Other health conditions can present with problems like sleep disturbance, poor initiation, or struggling to fall asleep, waking up earlier than you intend, and this becoming a chronic pattern, chronic pain, anxiety, either performance-related anxiety or general anxiety, or even having neurodevelopmental conditions like attention deficit hyperactive disorder and not getting treatment increases your level of frustration with your symptoms and increase your predisposition to developing depression. Some medications like corticosteroids, use in some health conditions like nephrotic syndromes and some autoimmune conditions where we have to suppress your immunity. You are put on some medications to help you with the health condition you are dealing with. But some of these medications do themselves also increase your risk of developing depression. Substance use and substance abuse. A lot of the stimulant medications or substances that we abuse have a withdrawal side effect of causing a lowering of your emotional state and leading to depression. And the most common of the substances we abuse, which is alcohol, is associated with 10%, 30% increased risks of depression in incidence of depression in users. And also drug abusers have been found to have an increased risk. So depression, how does it look like? Classically, we can put it into two big groups if we want to look at how it presents. And so when we do that, then we can say we have typical depressive episodes. And so if we have typical depressive episodes, then we can have the atypical depressive episodes. And oftentimes the atypical presentation, we see it in people who are in the extremes of ages. So very young children and very old people have the atypical presentation. If we also want to identify depression, looking at the severity of the condition in relation to how functional you are, because one of the myths we have when it comes to depression is that people who are depressed, they can't think far, like Luwen would say. They have lost the capacity to reason, or they are erratic. You can't understand them. They are unreasonable because sometimes they appear to have everything and yet they say they have nothing. They appear to have achieved so much and yet they feel life is worthless. Worse, so they even want to end their life. So based on the severity of the symptoms, we can identify three variant forms of depression. And when we classify it using this measure in terms of functionality, then we can say you either have mild depression, moderate depression, or severe depression. Let's go further. So when we say someone has mild depression, basically, it means that this person has depression, he has symptoms, he meets a specific definition criteria for having depression, but the person has not lost function. You see them, they get up in the morning, they dress up, they perform the activities of daily living, they take care of themselves, they go to work, they are managing their home, they are managing their life in all the dimensions they are in. They are functional, but they have depression. Then we say they have mild depression. Now, when we say someone has moderate depression, it means that this individual has symptoms of depression. In fact, the moderately depressed individual has more depressive symptoms than the one with mild depression. However, the one with moderate depression has noticed a reduction in their productivity. There's a decrease in their function, but there isn't complete loss of function. And usually in moderate depression, we'll see some other additional symptoms that are not present in the mild when we go into the symptoms. Now, when we say someone has severe depression, it means that this person is now not able to function. There's reduction in productivity. They may even be experiencing psychotic symptoms, and psychotic symptoms means their behavior is becoming disorganized, their thinking is becoming disorganized, their emotions are also not appropriate, and they may even be experiencing perceptual disturbances. What I mean, they might be seeing things that are not there, hearing voices as well, and also they might be feeling symptoms that make them want to end their life. So if even someone has moderate depression and it has any of the symptoms I will mention as significant for saying they have severe depression, then immediately the person moves from moderate to severe depression. So let's look deeper. When we say someone has depression, it means that for at least 2 weeks, which means that 2 weeks or more, the person has been experiencing what we call core symptoms. And the first core symptom is a lowering of your emotional states, okay? Feeling sad, feeling unhappy, feeling not your usual self for at least 2 weeks. And I mentioned that for people experiencing atypical depression, very young people or the elderly, this symptom will not be a lowering of mood, but an irritability, which is losing your tolerance with the slightest. Hassan, please lower your, mute yourself. Thank you very much. So those in the extremes of age, you might see agitation, you might see them getting angry or losing their patience with the slightest discomfort. And that is a feature of the atypical depressive symptoms in those in the extremes of age. The next point under this first core group of symptoms is loss of interest. That is losing interest in activities that previously gave you pleasure. So I used to enjoy singing, but for the past 2 weeks and more, I'm no longer interested in singing. I'm no longer interested in football. And it is not because I've outgrown that interest, no. And it is not because I no longer have access to it, but I have just lost interest in it. Then the third core feature is a sense of decreased energy, which usually presents as fatigue. And if you are observing the individual, they may appear to have become lazy. They may appear to be not moved to act or to respond. And these are the 3 core symptoms. And an individual is said to be depressed if they have at least 2 of these 3 core symptoms. So it could be that you are not experiencing the typical low mood or the atypical mood change, but you're experiencing low energy, loss of interest in previously pleasurable activities, or fatigue, just those 2. Or you may be having loss of interest and low mood, or low mood and decreased energy. So to any of the 2 combinations could be your core symptoms. Then you would need additionally at least 3 other symptoms, which are non-core symptoms, such as a reduction in your capacity to concentrate or to pay attention to detail, a decrease in your self-esteem and in your self-confidence. Again, ideas of guilt or feelings of unworthiness or worthlessness. Then a bleak or pessimistic view of the future. And here you see behavioral features that support this symptom in individuals with depression. Classically, people experiencing this, even in their choices, in their opinions to discussions, you see they tend to be pessimistic, or they tend to always seem to present only the negative aspect of situations. And again, another symptom that is non-core are ideas and acts of self-harm, an increase in carelessness or a decreased attention to one's safety is what you notice. And ideas of ending one's life or harming oneself. Typically, if you see an individual exhibiting signs of carelessness, little attention to their safety, or even attempting behaviors that endanger their life, this person might actually be in the category of moderate or even severe depression. Then sleep disturbance, and sleep disturbance can be at any of the 3 stages of sleep, problem with initiating sleep, problem with maintaining sleep, and when it gets worse, a complete loss of the capacity to sleep. Then a diminished in appetite, a loss of appetite, or a loss of the sensation for hunger is also one of the features that can be recognized. So if an individual has at least 2 of the core symptoms I mentioned, a low mood, a decrease in emotional state, or depending on the age, irritability or agitation or loss of tolerance for displeasure, a loss of interest or pleasure in activities that were previously pleasurable, low or decreased energy or easy fatigability, and the individual has any of the 3 non-core symptoms. So 2 of the core and any 3. So it could be attention, concentration, self-esteem, disturbance in sleep, or any combination, any additional 3. So 2 plus 3, then that person is said to be experiencing mild depression. And I just put a picture of it here. So we know the core symptoms and we know the non-core symptoms. And so any individual with any 2 of the core symptoms and any 3 of the non-core symptoms. So this picture, we are seeing the person with low mood, agitation or fatigue, difficulty concentrating, changes in appetite, sleep disturbance. And so our person we are seeing here is typically experiencing mild depressive symptoms. You want to check with this person if they have not experienced any loss 2 months prior to this experience. So loss of life or loss of an investment or loss of an expectation. You want to rule it out because normal grief can present with symptoms that resemble depression. If we had time, we would have looked at our friend Sarah here. She had a few symptoms. Maybe we'll come back to that and see whether what Sarah was having. And a few people have seen the answer, but we'll move on. So we've talked about the fact that there are 3 varieties based on severity. So let's move to help us tell the mild depression from the moderate or the severe. There are 2 important things that helps us to distinguish between these 2 broad groups. Once the individual is not able to carry out their usual activities of daily living, it could be usual workload, school work, domestic work, social activities, then yes, that individual is experiencing moderate to severe depression. And I mentioned that the difference is that the person with mild depression is able to perform all these normal activities on a daily basis, whilst our individual with moderate to severe depression is not able to do that or has seen significant impairment in their capacity to perform activities of daily living. Persons in the category for mild depression usually do not require biological intervention or medication. They usually do very well with psychotherapy, which is a specialized setting for engaging with a professional to help you go through your life and identify your risk factors, help you prioritize which risk factors to address at what time, set reasonable targets, help you reduce your risk of stress load, and help you perform risk relieving activities to help you recover from mild depression. And I mentioned that individuals with the extremes of age typically please mute yourself. Bosomche Ankoma, please mute yourself. So I want us to look briefly at the atypical presentation. And I said that classically, persons in the extremes of age tend to show the atypical presentation. Here we're looking at a child or an adolescent and they will present with more somatic symptoms. When we say somatic symptoms, we are referring to behaviors like eating, so change in eating. And for young children, it might even appear as if a change in tastes or a change in preference of food or a change in the quantity of food they go for. And they are eating portions that are below their usual portions. Again, symptoms of sleep difficulties are some of the common things we see in children. Older children, you will notice trouble with school performance, and you find that they tend to be absent-minded and are easily distracted, are not able to complete tasks. In adolescence, they are able to recognize their symptoms. So they might be able to express to you that they are unhappy, that they are sad, that they are bored, that they don't feel good enough, they don't feel adequate enough. So we need to be aware of the variations of presentation across the age groups so that we can identify the atypical symptoms. Again, children and adolescents, you will notice behavior problems. Children who were very affable and not demanding become very demanding and very irritable. So you see a lot of tantrums coming up, and behaviors that were not classical of the children become an almost norm, a new norm. And when you see these, you may want to consider that the child or the adolescent may be experiencing depression, and you want to investigate and find out what risk factors. Again, among the age group of children and adolescents, I must mention some of the stresses include bullying or even abuse, some oppression or teasing that they may be encountering in some circles might be what it is, and you may need to gain their confidence in order for them to reveal to you the difficulty. And in elderly, the symptoms are sometimes similar to the symptoms we notice in dementia. So memory deficits are very common in people in the extremes of age. And then younger people, the middle age groups, you'll find more of self-harm, alcohol use being very common. In some extreme situations, you might even see an increase in some presentations like epilepsy, convulsions. In younger children, you may notice bedwetting or enuresis or a regression in the child's development when they are having depression. Caregivers of adults and children with mental and neurological disorders have also been found to have an increased risk, and they may also present atypically. So depression tends to have a cycle of symptoms. As long as the depression exists, there will be the experience of low energy and fatigue. And then the individual begins to use coping strategies and skills to help them deal with the symptoms they're experiencing. And this generates anxiety, and the anxiety reduces the risks, reduces the experience of discomfort they have. And if it is a poor coping skill like taking substance or alcohol use or behaviors that are not appropriate, it generates an increased sense of guilt, a sense of hopelessness or ineffectiveness, which further feeds into the experience of depression. So depression can actually worsen into a vicious cycle which will need to be broken. How do we handle depression once we've been able to identify the symptoms and we are able to tell this is mild, this is moderate, this is severe? How do we go about it? You need to establish rapport. You need to reach out if you are the one experiencing it to get help from a professional. If you are the one who has noticed it in another person, you need to get close to the person and please commit to be a shoulder to lean on and engage to gather the history, to get a person to tell you the story of what they are going through. And that forms the history. Because with that, we're able to categorize the symptoms and tell the stage the person is. Then it is important to do a physical examination because we've recognized that there are so many other things apart from the biochemical imbalances that result in depression. It could be physical health problems, trauma, etc. We saw it earlier. So you need to complete a thorough physical examination to identify, is it a nutritional deficiency? Is it a chronic condition, etc.? Is it hormonal, premenstrual, postpartum, etc.? Physically assess the person to be able to rule out any other physical condition that is present. Because if there's a physical condition, you need to treat it in order to help the person be rid of the depression. Otherwise, if you treat just the depression, the underlying cause will still perpetuate the depressive symptoms. Then you need to conduct a mental state examination. This is the physical examination of the brain, where you talk with the person and you pick up symptoms. And you definitely have to investigate. You may have to take labs, you may have to talk to other family members for psychological history. We saw social support deficits, so find out they've lost their job, lost their loved ones. All these are investigations. Sometimes personality investigations are important to determine whether they are a type A individual who is prone to anxiety, certain high expectations, not meeting them, and that is the risk. You want to conduct a psychological investigation or a social investigation. Are they suffering neglect or abuse in the home, spousal abuse, parental meltdown, overstimulation of a young mother? What is it? Investigate it. And then once you've identified the risk factors, predisposing, precipitating, the ones that are perpetuating the condition, then now you plan your management. And the treatment should be in 3 areas: biological, psychological, and social. Biological means we are trying to restore the hormonal levels to levels that will relieve the individual of the symptoms they're experiencing. And so based on the age and the nature of the symptoms, you may go in for an SSRI, a TCA, or an MAOA. The MAOs, we don't often go for them because a lot of our foods are fermented. And the fermented foods contain compounds that interact with MAOs and can lead to cardiac toxicity. So we don't often go for them. Then you want to educate the individual well about the need to be compliant with treatments and to make lifestyle changes. So psychological management is very critical, and your investigations will reveal poor coping behaviors, poor coping strategies, skewed or abnormal thought processes that need to be changed, poor time management, poor stress management, poor lifestyle. And they may need the psychologist to have several sessions with them to change the way they are dealing with their life challenges in order to get rid of these risk factors. Then the social treatment includes what? Reactivating their social support. Even the one who is an orphan might be part of a group, a school group, a church group, a social group. And it should be possible to find some individuals from these special groups to build some form of social support for the individual because it is critical for their recovery. encourage the person to participate in social activities. And this is where I want to share a small tip of recent findings, guidelines from the Canadian Society of Psychiatry when it comes to managing depression. Now, the new recommendation is that for people in the low to moderate category of depression, as part of your social and psychological intervention, you want to encourage the person to have 30 to 40 minutes of intensive activity or exercise, at least 3 to 4 times a week for a minimum of 8 weeks. So 4 times a week, let's say 3 to 4 days in a week, 30 to 40 minutes of exercise or activity is very helpful. And then also the fact that with the biological treatment, it's recommended that you try one medication. So monotherapy is ideal for mild depression. And as the severity increases, you might want to bring in a second line adjunct or a medication that will support the primary medication for moderate depression. Then we also have light therapy, because some of the risk factors for depression have been associated with daylight patterns. So persons on the parts of the globe where there is decreased sun activity have been noticed with seasonal episodes of depression. So if you find yourself in that setting, then as first line, you have monotherapy, and then you also want to recommend light therapy for such individuals. Now, persons with severe depression who are now having perceptual problems or what we call psychotic problems, then the combination of your antidepressant with an antipsychotic medication is what is recommended. And for all these categories, cognitive behavior therapy is first line. Interpersonal therapy is also recommended. Behavior activation, so encourage the person, join a club, join a quad, join a group, and participate in the activities. This is very recommended for first line in psychological treatment for those with major or severe depression. And for antipsychotics, some medications like aripiprazole is recommended. And also to consider that the possibility of optimizing treatment so that if possible, up to about 12 months, you should have the patient going into remission. And if possible, even have considerations about tapering them off the medication if they have significant improvement or they are in remission for that good amount of time. There are new agents on the block like S-ketamine, ketamine infusions, repetitive transcranial magnetic stimulation, which have also been found to be very useful. And on that note, I want to leave us with these few images that to help us prevent depression, we see that we need to engage in some things. One, physical self-care is very important. Mental and emotional self-care is critical. Social support is very important. Spiritual connection is also important. Lifestyle habits play a crucial role, and prevention is also very important. All these pieces should be part of the puzzle for managing depression. And once the case comes, you want to assess the patient, their presentations and suggestions prior to the condition happening. And then you want to look at the stage they are, the investigations necessary, identify the level of severity they have, develop a management plan, and encourage the individual to stick to the management plan. For psychological treatment, for medical and social treatment to be effective, it's important that the person gets good education. Misinformation is worse than no information. So good psychoeducation about the condition, the risk factors, the protective factors, the changes that are important is critical. Addressing the current psychosocial stresses, reactivating social network, communicating well is also very important. We saw the effect of interpersonal conflicts. And for our recall, I said, offer the opportunity to talk in private. If you are dealing with the individual, you want to ask about current stresses, ask about available resources they have for support, investigate if there's any abuse going on, brainstorm with the person, help the person figure out some of the solutions on their own. You don't want to be dictating the solutions, because once they leave your consulting, all those suggestions are gone. Involve supportive family members, and this has to be with consent. You don't want to bring in an individual who is part of their social support, who is the main figure for the interpersonal conflicts, then you are going to worsen it. So you want to recommend someone that the client is comfortable with and has nominated as their social support. And you want to encourage their involvement in self-help or family support group therapy sessions. You want to help the person recognize when they are stressed up and to do something about it. You want to identify psychosocial stresses. I mentioned the marital, spousal, family challenges, etc., and work at them. You want to activate their psychosocial support system, because these are the protectors to preventing them from having a relapse or recovering from the condition. And involving the social support members is going to help prevent and protect the individuals from recurrence. I will pause here so that we can discuss or ask a few questions. I know our time is run out, but let's interact at this point.
Yes, Dr. Pearl. Yes, Dr. Pearl, thank you very much for your presentation. You've done a very good job. I think you've clearly explained what mood disorders are, and I'm sure we've all learned something. At this stage, the floor is open for questions. You can put your questions in the comment section. I'll read them out. You can equally use the hand sign. You raise your hand and then you unmute and then ask your question. Okay. Once again, I just want us to know that this is an initiative of the KNUST Wellness Center in collaboration with the Behavioral Sciences Department, KNUST Counseling Center, and then St. Patrick's Wellness Center at the St. Patrick's Hospital at Offenso. I think Nana Pia, you can ask your question, Mr.
Okay, thank you. Please, my question is it's on the management of depression, how to help people who is depressed, the steps involved and other things. So as a psychologist or as a doctor helping a person who is depressed, I would like to know, let's say, is suffering from academic issues. Maybe he or she is failing an exams and is depressed or stressed from as a result of the failure in that particular paper. So as a psychologist, you are there to help the person when he or she is depressed. So the thing is, why not provide the direct solution to the problem? Let's say the student is failing, okay, and he needs the marks to reach where he or she will not fail. So as either a lecturer or a psychologist, you are there to help manage that problem. So why not provide a direct solution instead of talking to the person, saying it shall well, providing all the management tactics and stuff, and not give the direct solution. Let's say I'll give you this mark, so the person will be happy and come out of the depression. Thank you.
Okay, fine.
You are muted.
Yes, I just realized that. That is an interesting one. Dr. ADU-NYARKO, I'm curious as to how you're going to respond to this.
So I have made it simple. I'm showing a slide that should help you. With everything I've said, I've tried to help you understand that it goes beyond just the current crisis, which is failing exams. There are so many more changes that have gone on in this person than just the exam. So you will need to go through the process. There is no shortcut. If you do not identify the problem from its roots, you might be just looking at a fruit instead of the root cause of the problem. So this person who is failing exams is probably failing exam because there is impaired concentration and attention. And if that is the case and you do not go through the process of investigating what the problem is, you might even give the person all the answers to the next exam, and they'll sit in the exam room and will not be able to recall the answers you've given, and they will fail. And the next time you wake up, they would have completed suicide because that shortcut just helped them reinforce the feeling of worthlessness that they are experiencing because of the depression. So I hoped to show that depression goes beyond just the symptoms. There are biochemical changes that have occurred. There are risk factors that are present. Some of them is because of physical illness. And so if there's physical illness and you treat it, you've identified that that is the cause. Maybe they are hypothyroid. So it's an endocrine problem. If you don't identify that and you're looking at just the failure in exams, you give them the marks, the next time they will come to you because they have failed in something else. And what you'll be doing is reinforcing the feeling of helplessness and worthlessness and not correcting the abnormality. And it is important to understand that handling depression is like telling someone with hypertension, keep your blood pressure normal without doing anything physically about it. Is it possible? No, it is not. That is why it is a recognized functional disorder. It's not just about, oh, I failed an exam and therefore I can't handle it. I'm not brave enough. I'm not resilient enough. It goes and listen to the whole story and identify all the risk factors that are present for this individual. You might discover that there are other conditions in addition to the depression you are seeing. And even the depression might even be a secondary presentation, and there's a primary condition. So you need to identify the root cause. Now you want to prioritize the problems you identify. So if your investigation shows that, oh, this student is going through a lot of psychosocial stresses, they just lost their mother, and then they've lost their father too. And so when they come to school, they are preoccupied with how they are going to fend for themselves. And that is how come their sleep got disturbed. They began to feel sad. They lost concentration and attention, and they are failing their exams. If this is the history you've gotten, then it is not providing the answers to the exam questions that will solve it. You need to help the person now prioritize their problems. And that will help you choose what to deal with first. And once you go by that approach, you select the problem to be addressed first. And together with the person, you now look at the possible solutions to the problem. Sometimes it means, oh, you have to go for surgery. It means you may have to defer your program until we treat this underlying health condition. Or we need to find sponsors for you. Or whatever the solution might be, you need to prioritize which is the most important and address it. Pick the most appropriate solution and implement that solution. Sometimes, if you go through this process, you find that a lot of the effort was psychosocial, and you didn't even need biological agents to come in, and you have solved the problem. So it is important that you pick the problem-solving technique to dealing with depression so that you can be effective in managing it. But Auntie Ohinewa, please add on to it, because
no, I think you've done a good job. I think I'm amazed by your response. I think I like your response better than the version I have in my head. So I'll stick with yours.
Yes. So
Okay.
like I was saying, yeah, great. Go ahead. So
okay. There are questions in the chat segment I think you should respond to. So Mr. Paul Apia wants to know, what can one do to overcome premenstrual depression?
Good. So again, I won't change the slide because it follows the same approach. You have identified that the problem is premenstrual. And by premenstrual, it means that we are dealing with hormonal fluctuations that are responsible for it. So this is a purely liaison-based condition. This client needs to be in touch with their gynecologist. And so we'll work together with the gynecologist. And when I say we, I mean the psychiatrists and the psychologists, and if possible, the occupational therapists. We will be working together with this client, with the gynecologist, to look at what is the most effective way of dealing with these hormones that are the predisposing factors for this client's condition. And there are a number of approaches. Please help. Thank you. My namesake. Please mute yourself.
Okay.
So there are two approaches. There's the hormone replacement approach, and also there's the symptomatic treatment approach. So based on the reproductive stage, again, you see we are prioritizing the problems. If this person is in a stage where they want to have children and they're experiencing premenstrual problems, then when we go for hormone replacement, what we might be doing is delaying their fertility so that they get relief from the depression. And if this person is trying to have children, I don't think that will be the way to solve the problem. So we'll look for the most suitable approach to this situation for the one with premenstrual depression. And then psychoeducation is important to help the person identify why we are taking this solution to get their compliance and what timelines we are taking this approach for. And once we are on the same page, we will be in the best of books. We control the symptoms. If the person wants to have children, we know that, oh, for this period, we are trying to have a baby, we'll go with symptomatic treatment. So you'll be taking medications to help with the symptoms, which are secondary to the menstrual problems. We have our baby, and if we are lucky and we are no longer experiencing it, because you see, being exposed to the menstrual cycle out of pregnancy presents the risk for people with premenstrual depression having severe symptoms. So sometimes once they get pregnant, they have a baby, the changes that go on, they get relief and they are fine. If not, because of your psychotherapy, psychological interventions, they'll be in a better place to cope better with their symptoms.
Okay, thank you, Doc. So there's another question for you. What do I do about a friend who is clearly going through depression and I've tried to help, but the person isn't getting better and doesn't want to see a counselor?
Great. So your friend is in denial, I must say, but you are identifying that they are probably in the moderate to severe category. Because as I mentioned, those in the mild category are functional, and usually they need just some psychological support. Okay, so with your social support, being there for them, helping them through difficult times, If he or she was mild, there should be relief of symptoms. But it is obvious that they are the functional state where they have lost functions. They're either moderate or even, I must say, they might be in the severe category. If that is the case, please, you need to encourage the friend to be able to move beyond stigma and accept them some help. Sometimes the challenge is seeing the clinician in the psychiatric environment. So I actually encourage people with sight difficulties to consider virtual consultation with a psychologist or a psychiatrist, or even sometimes I offer out of clinic settings for such an individual. This person might even benefit from home care. So you can talk to a clinician and arrange and support a home visit care. And once the psychologist comes in and we are able to help the person realize the severity of the condition on their health, I must say, if they are not already far gone, they will be willing to get the help. But it is important that if your friend is having frequent suicidal attempts, self-harm attempts, and risking their life, then you want to keep a close eye on this friend. If it's your child, you want them to be in a safe environment where there are no items that they can use to complete a suicide attempt, and they may need to be hospitalized. If you find that they are having more than 2 attempts at self-harm within a week or within a month, that is quite significant. They will need to be hospitalized for treatment.
Okay, so just to flesh up what Dr. ADU-NYARKO has said, so one thing about psychotherapy is that you can't force people to seek for help. Okay. Yeah. Aside from encouraging the person, you can just be there for the person, because at this moment, it's obvious that you form a strong social support system for that individual. So focus on that role more instead of sort of subtly putting pressure on them to speak to someone. It's not every form. For instance, if it's a mild depression, they probably don't need to speak to someone. They just need someone to be there for them, someone that they can call on at any point in time during the day, that they can actually sort of pour out their heart to. Okay, so it's unfortunate you're in that position. I'm sorry about that. However, at this moment, you need to be the support system for this individual until they are able to overcome the stigma and decide to speak to a professional. Thank you very much. So there's another question for us. Adolescents face depression during that stage, during the period of adolescence. How can a teacher / educational psychologist help in managing depression among learners? That's part one of the question. And part two is, are all depression situations clinical? Over to you, Doctor.
Great. So these 2 questions, I think I talked about them. I clearly mentioned that for children and adolescents, their presentation is different from the middle age group. And I mentioned change in behavior, change in eating pattern, change in sleep, change in their tolerance of discomfort, decreased academic performance in children and in adolescents. And also, you may even be able to pick the time of onset as having begun as soon as they entered into adolescence. Then you've noticed the change. So the first thing a teacher can do is to know your students. Recognize that all your students are different, so that when they are changing, especially if you're in the adolescent year group, you're a class teacher in the adolescent year group, it will be important that you get to know them. How do you do that? You might need to find out from the previous year's teacher how this particular student was like. When you've noticed any of these changes, and you may want to talk to their parents also to find out, I have noticed this about your child. You might even want to let the parents tell you about the child first, before you mention your observations, so that together, that is the investigation aspect of the process, so that together you might be able to recognize then there is something going on. And you need to conduct further investigation, because the adolescent age group is filled with a lot of very self-confident individuals. And they can be very mean. There's a lot of bullying that goes on. That's the age group where you can be told that your head looks like a pencil, or your hair or your face looks like something that is not even living.
I used to have an interesting terminology. They used to call me December head.
Wow.
Way back in school.
Yeah. So
and my mom used to get angry by that.
You see, that age group is going through a lot. Identity issues, self-autonomy issues, industry, everybody trying to show that they there. You know, peer pressure begins to come up at that stage. Being actualized to some extent might even be one of the difficulties they'll be struggling with. And that age group, they go through a lot of social stresses. And that might be what is contributing to this. Your investigation would reveal that. And as a teacher, some of your interventions might even be as simple as changing the child's sitting position. We have children who get punished all the time because there's someone they are sitting by who is always talking, and that person talks and is not seen. But as soon as they react, then they are found out. So they are constantly subjected to punishment. So the teacher, know your child, be able to recognize the change, investigate it thoroughly. And once you've identified it, there are parents who are in denial about their children's condition. And like we mentioned, you may want to gently encourage them to seek help. And that's how far you can go. If the parents are in denial and will not get help, you, the teacher, being reassuring, providing a good social support for the child, taking away bullies, supporting their studies, can all help relieve the stress they encounter and improve on their symptoms, at least if they are in the mild category.
Okay. So let me add up as well to this. Of course, the reason I keep adding up is because I'm coming from the clinical psychology field, and Dr. Paul is from the psychiatry, so we complement each other. Don't worry, but don't be well,
I'm expecting it actually.
Yes, let me just go on to what I want to say. So for some kids, as Dr. Pearl rightly said, watch out for the signs and symptoms. And as an educational psychologist or a teacher, you would want to explore such kids' social support. Okay, so not all kids are comfortable discussing issues with their teachers, or because you are an educational psychologist, they should see you. No, don't force kids to open up to you when they don't want to. You can rather observe to see if there are any other there's any other teacher that they are comfortable with, that they go around that teacher, play with that teacher, and encourage the teacher to perhaps explore what you have observed differently from this individual. In as much as you want to provide that sort of social psychosocial support, do not force the kid to open up to you. Kids have to be comfortable with you enough. They need to sort of trust you with whatever information they have within them. The minute you force them, you lose the help, the sort of help, the core tenets of the help that you want to give. Okay, so observe to see if there are any other teachers that they are most comfortable with. Encourage the teachers to rather explore what you have observed. Don't go and tell the students to speak to these teachers, because then it becomes as if their issue that they thought they were sort of protecting is actually known to everyone. You rather encourage the teachers to approach them and then perhaps make the same observations that you have. If the student is comfortable talking to you, all the better. Yeah. Then you can engage them, explore their social support system, see how best you can assist them. Okay, or how best you can strengthen their social support system. That understanding. Let's go on to the next question. Yeah. So the next question, Doc, what is the difference between mood disorder and then mood swings?
So, Abdul Nazar, please mute yourself. So
we are almost through. Please kindly hold on. We'll just take the last two questions and then we are done.
So mood swing is more of a lay term.
Thank all of us for joining in for today's Psych Gist. It's been an interesting discussion on mood disorders. And let's watch out for next month's episode on Psych Gist. This is a collaborative initiative between Kenya State Wellness Center, Kenya State Behavioral Sciences Department, and then Kenya State Counseling Center, as well as the psychiatric St. Patrick's Wellness Clinic. So, I mean, this is very informative, an informative session for ourselves, and then for the doctors online, for our patients, it will help us to deal with our patients as well. While we are still, okay, so the major difference between mood swings and the mood disorder is that for mood disorders, we have classification of it, characteristics of it, how long it should have occurred, the frequency, the intensity, and then the duration of it. Of course, the mood swings are just lay terms that we use to describe people swinging from mood changes, swinging from one mood episode to the other mood episode. But contrary to what we think it is, the frequency, intensity, and the duration of it helps us to determine if it is a disorder or it's just a regular mood swing episode, basically. Okay, I hope that clarifies it. Then depression affects a person's physical health? Definitely. Of course, Dr. Pearl explained that when someone is depressed, it has serious implications for the individual. There's insomnia for some people, even with your eating habits, your nutrition habits. It changes. There's significant changes in them. Of course, the minute there are changes in your sleep pattern and then your nutrition pattern as well, definitely is going to have a negative impact on your health system. So the activity of the immune system declines. You don't feel like engaging in any activity. You don't feel like eating. Definitely you are depriving the body of some form of nutrition. And then if you're able to sleep well, that also has implication for your physical health. So definitely, depression does impact our physical health. Then there's another question over here. I think the last. Across the social media, you can see youth pretending to be depressed. Maybe they need attention, or maybe they don't understand what it means to be depressed. So can we classify this act as depression? Well, arguably you can do that. The minute you're saying they are pretending to be depressed, the terminology over there changes the category. If you are pretending, it's obvious that you're not depressed, but it means that you have a cognitive distortion. There's an issue with your self-image. Why do you need to pretend to get attention? Okay, that is also another psychological disorder on its own. Okay, once there's a cognitive distortion between you as an individual, your self-identity as an individual, and then the self-identity you want to project to the community, you need to explore that in therapy. If you think there's a need to fake an illness to gain attention, then it means you have a problem, that you need to speak to a professional. So it may not necessarily be categorized as depression. The act itself is pretentious, so it can be categorized as depression, but it can be categorized as another psychological disorder. Okay. Thank you very much. It's been an exciting episode. Please watch out for the next episode and please join us as well so that we can have an interesting discussion. Until next month,
Thank you, madam.
it's Psygist. Please remain tuned. Glue to all our media channels for updates on what we are doing next. And then join our fan page if you can. Okay? Have a blessed day. Thank you.